Good morning or good afternoon, depending on where you are. Welcome to the Monkeypox update, sponsored by the Bay Area Global Health Alliance and the Institute for Global Health Sciences at UCSF. I am Mary Pittman. I am the CEO and president of the Public Health Institute and chair of the Bay Area Global Health Alliance Board of Directors. We are coming together today with UCSF Institute of Global Health Science and other leaders from across multiple sectors to provide a brief update on the monkeypox crisis. Monkeypox is now an international, national, and state public health emergency, and there are new cases reported from countries where the disease is not endemic. This is the first time that many monkeypox cases and clusters have been reported concurrently in endemic and in non-endemic countries and are widely disparate geographical areas. It is now a global health challenge that we face here in the Bay Area and beyond. And this is another global health challenge on top of the COVID pandemic that we are already continuing to work on. Today's convening is an example of the work of the Bay Area Global Health Alliance. We are a unique global health community with more than 65 member organizations from diverse sectors, from academia, NGOs, nonprofits, the tech companies, as well as other private sector companies. Together, we build cross-sector connections and collective intelligence, like this webinar. Our aim is to advance global health equity by leveraging the innovation ethos of our region and beyond. In today's conversation, if we could put the next slide up, thank you. You'll be hearing from an incredible lineup of experts. Dr. George Rutherford, UCSF Professor of Epidemiology and Biostatistics. He's the Director of Prevention and Public Health and the Acting Director of the Institute for Global Health Sciences. Dr. Sarah Cody is the Santa Clara County Health Officer and Public Health Director. Dr. Peter Chin Hong is a UCSF Professor of Medicine. Dr. Michelle Berry is on the Bay Area Global Health Alliance Board, and she is a Stanford Professor of Medicine and Director of CIGH of the Center for Innovation in Global Health and Senior Associate Dean for Global Health. Brett Andrews is CEO of San Francisco's Positive Resource Center. Clarissa Ospina-Novell is the interim medical director and a nurse practitioner at the San Francisco Community Health Center. Then we will hear from Dr. Huma Abbasi, who's Chevron's chief medical officer and also a Bay Area Global Health Alliance board member. She'll be joining us via recorded video. And her colleague, Mike Steinberg, is here as the team lead of Global Public Health and Special Projects from Chevron. So to begin the discussion, let me please hand it off to our co-host and my longtime colleague, George Rutherford. George?
Thank you so much, Mary. It's a pleasure to be with all of you this morning. May I have the next slide, please? Do we have that going, or should I put them up? Here we go. I'm going to skip ahead here a little bit because I know Michelle's going to cover this stuff. So let's just stop right here. So so monkeypox or mpox, or name to be named later, pox, was originally described in Zaire, in the Belgian Congo in 1958 in a primate research center. And it was mistakenly believed to be a disease of monkeys. It's actually probably a disease of small rodents in both Central Africa as well as West Africa. The current outbreak, and there are two separate clades, one so-called clade 1 and the other, surprisingly, clade 2. Clade 2 is what the West African one, and there's a clade 2b, as in Bravo. That's the clade, that's the subclade that's been associated with this outbreak. There was increasing evidence of sexual transmission of monkeypox in Nigeria in 2021. And then there was a series of importations to Europe, probably mostly to the UK. But there was a couple of big amplifying events in raves in Spain and Belgium in May of 2022. It spread from Europe, England, Spain, Germany, throughout the world, with cases in the US and Canada, Brazil, and Peru actually has a number of cases, as well as east to Australia, as you can imagine. It's now in 91 cases, 91 countries, in which it has not been, in which it's not typically reported, from which it's not typically reported. And there have been about 45,000 cases reported worldwide. The next one, please, as part of this outbreak. So this is overwhelmingly a disease of men who have sex with men. 98 to 99% of all reported cases are male. And it seems to be from sexual contact, not sexual intercourse per se, but more skin-to-skin contact. You can see over here in the box, the U.S. leads the world in cases with more than 16,000, followed by Spain, Brazil, Germany, UK, France, Peru, and Canada. There has been some slowing down in Europe, and I'll show you the last slide, which may reflect vaccination efforts. It may reflect behavior change. It may very well reflect natural immunity. This is very rare in the U.S., very rare in children, whereas previous outbreaks have involved children. And there have been 12 deaths reported worldwide, 4 from Nigeria, 2 from the Central African Republic, 2 from Spain, 1 from Brazil, 1 from Ecuador, 1 from Ghana, and 1 from India. The next slide, please. So there are the U.S. outbreak, 16,603 cases and no deaths, with the highest number of cases in California, in New York, California, Florida, Texas, Georgia, and Illinois. The next one, please. Want to go back and forth again? See if we can make this better. Okay, next. Yeah, there we go. In California, there have been 3,065 cases reported. This is the actual right number. I think I had an old numbers up. San Francisco has about a fifth of the cases. And you can see 3 of the 6 counties with the highest number of cases in California are in the Bay Area. So Los Angeles with 1,100, San Francisco with 650, San Diego, Alameda, Riverside, and Santa Clara. Surprisingly, what's come out more recently is that this is the state health department now feels that this is a disproportionate disease that's disproportionately affected Latino men, and are trying to deploy resources accordingly. And we look forward to hearing what Dr. Cody has to say. The next one, please. The interesting thing is that there is some evidence that this may be waning. There's all this artifact in here from from not reporting on weekends, but you get this sort of impression that this curve is starting to turn over, and it may be too early to call, but that's at least there's some suggestion of that. And the next one, please. CDC has done a large survey of MSM in the U.S., and this was very recently. 48% reported reducing the number of sexual partners, 50% reduced one-time sexual encounters, and 49% reported reducing sex with partners met on dating apps or at sex venues. And then the next one, please. The last one. This is from the European CDC, which doesn't include Britain. But you can see that this is what their curve is looking like. This probably represents some lag out here, but you get the distinct impression that this is starting to turn over. So I'll stop there and give it back to Mary. Thank you very much for inviting me.
Thank you so much, George. There was a request in the Q&A, Sarah, to please turn on captions if that can be done. If someone would do that, please. George, you and I have been through a couple of public health emergencies together, from HIV back in the San Francisco Health Department to COVID. Why wasn't the U.S. more proactive on monkeypox? And if you could describe from an epidemiologist perspective, at what point should there be a trigger to, one, be paying more attention, and two, to apprise the public?
I think that I don't think that we really lag behind very much. I think there's always some lag when you look back in retrospect. But we have the vaccine. Yes, there could have been lots more, but it's made in Europe. The company's called Bavarian Nordic or Nordic Bavarian or something like that, just to give you an idea. It's not from Kansas. So we have limited triggers that we can apply to having them make more vaccine. The drugs are in relatively ample supply. Peter might want to comment on that a little bit more. But I think we have the tools. I think we have we don't have enough vaccine. That's what's turned out to be obvious. But I think we've done a reasonable job of keeping this under control. I mean, we have 600 cases in San Francisco, 650 cases in San Francisco, where they have twice as many in Los Angeles. So it seems to me that there's some, and there are signs that it's starting to go down. So I think we may have kind of hit the right formula, maybe a week or two late, but still we're there much more rapidly than we were with COVID.
I'll put that question out to the others later after your presentations, just to help us understand whether from your perspective we've moved fast enough and what else we might have done. And maybe in the Bay Area, there's a little more awareness, but there are a lot of parts of the country where I think we're still probably lagging. So with that, why don't we now move on to Dr. Sarah Cody?
Great, thanks so much. I'm going to share with you just our local experience here in Santa Clara County. I only have a few slides, so maybe I won't even take my whole 5 minutes. So if I could just have the first slide. This gives you an overview of what the epidemic curve looks like in Santa Clara County. And like the state curve that George just shared, this is by episode date. So it's sort of the earliest of many dates. And we didn't really see much of a dramatic rise. It's sort of been slow and steady with maybe a little bit more clustering in July. And it also looks like maybe some early signs that things are tapering off. We didn't have our first case until late June, and this was in a traveler returning from, I think, Copenhagen, and they'd attended a large event there. Our second case, I believe, was also in a traveler, not related to the first, and then the subsequent ones primarily were not among travelers. They were probably community transmission here, somewhere in the Bay Area. We just sort of, to put a timeline on this, we didn't really have vaccine and didn't start doing really much vaccination until late July. And of course, we've not done that much vaccination because we don't have that much vaccine, unfortunately. But just to give a sense that the first half of this was without vaccine and the second half was with a sprinkle of vaccine. So the next slide, I'm just going to show you a couple times what the patterns that we're seeing in Santa Clara County, of course, are quite similar to the patterns across the state and across the country. Next slide. They are overwhelmingly among over 2/3 are between, or almost 2/3 are between 25 and 44. So it's a young group. Next slide. And in our county, over half are Latinx. The population in Santa Clara County, the Latinx population in Santa Clara County is about 25% or maybe a smidge more. So this is almost double what we would expect. And I think that the disparity in our county is more pronounced than what you see in the state. Almost all of our cases are among men, and predominantly among men who self-report as being gay or bisexual. We've spent a fair bit of time. I think that many of our handful of cases that identify as heterosexual or straight, I think they may identify as heterosexual straight, but I think that there are the folks that are talking with them sense that they may identify as gay or straight, but may also have sex with men, some of them. Next slide. I wanted to talk, see if we could load it. I just wanted to touch on some challenges. These are the challenges of a local health department. I don't think it's loading, but I'll talk about the challenges even as it's loading. The first one is vaccines. So I think the core problem that we see in Santa Clara County, the Bay Area, is the inequitable distribution of a limited supply of vaccine. So for example, in California, for historical and political reasons, Los Angeles County gets vaccine directly allocated from the federal government. All other counties get it through the state's allocation, and then there's a formula to pass it to the counties. So what you end up with is real disparities between access to vaccine in LA and access to vaccine in the Bay Area. So the case rate in the Bay Area, across the Bay Area, 9 Bay Area counties, is twice the case rate in LA. But the Bay Area has had just a fraction of the vaccine, and that's just not right. that just doesn't make sense. So in the Bay Area, we're still primarily able to just give first doses, and then second doses just to those who are moderately or severely immunocompromised. The second thing, second challenge I think is around transmission and all that we don't know about transmission, with the Mpox virus spreading here, behaving differently, as George mentioned. And I don't think we have a good understanding about the degree of pre-symptomatic transmission or asymptomatic transmission, or the proportion of cases that might be not skin-on-skin contact that you would have during an intimate encounter, but sexually transmitted. And this matters. This is important because it matters about how we communicate about Mpox and what the risk is and what the prevention strategies are that we recommend. And this brings me to the third challenge, the communication challenge, particularly after COVID, where I think there were so many missteps in clear, honest, up-to-date communication about the risks of COVID. I think that with Mpox, there's really very little margin for error, and we need to get this right. And the messages need to be tailored. They're going to be need to be a little bit different for different audiences. And then finally, sort of a global challenge is that, like the healthcare delivery workforce, the public health workforce is just bone tired. In our department, I know I've been really reticent to ask for to ask more of people because they are so tired, but there's not really any choice. So we've pulled some off of the COVID response to respond to Mpox. One of the challenges, of course, is that the COVID funding, all these injects of multi-year grants, for the most part, we are not allowed to spend on Mpox. They are just for COVID. So that means relying on just general positions to get the work done, which is quite a challenge. I'll stop there and happy to take questions now or later. Thanks.
Thanks so much, Sarah. And I know that we'll be getting to some questions from the audience after all of our panelists have spoken, but you raised a number of issues that I wondered if you might just briefly touch on, that talk about how our overall public health system is not necessarily structured, and the funding flows are not necessarily optimal, particularly when you're dealing with an emerging infection or a crisis situation. There are conversations about some restructuring and reorientation at CDC. Have you and some of your colleagues thought a little bit about what might be able to facilitate you being able to effectively and rapidly respond to something like monkeypox?
Yes, we of course have given this a lot of thought and a lot of conversation. I think the bottom line is that while there have been many investments in healthcare delivery, there not only have not been investments in public health, but there have been disinvestments in public health. Like public health budgets have shrunk, public health workforces have shrunk over the last 10, 15 years. So we were in a particularly poor position to respond to a public health emergency, much less multiple public health emergencies. And the main issue that I see is that public health funding in general is all generally categorical. You get this funding for TB, you get this funding for HIV, you get this funding for maternal child health. It's not flexible funding that we can use how we need to. Having fund, the funding comes, like you get a spritz from the fire hose and then you get nothing. And that's it's just pretty impossible to develop an infrastructure with funding flowing in that way. And then I would also say, the way funding flows, some of it flowing directly to jurisdictions and then some of it funding through the state, it just doesn't make a lick of sense. It just doesn't make a lick of sense. So it just needs some standardization.
That's great. Sarah, let me thank you on behalf of all of us, and I know across the state, we are so appreciative of what public health has been doing. We know you're bone tired, we know you're challenged, and I just want to acknowledge that and thank you. We're probably not going to have time for me to ask each person individually a question after their presentation, so I want to move on to Dr. Chin Hong, and then we will take some more of the questions at the end of all the presentations. Thank you. Peter?
Great. Thanks so much, Mary. Today, I'm going to do it old school and just talk to you with the 5 minutes that I have. What I'm going to do is really focus my comments on the clinical presentation, treatment, together with diagnostics, and speak a little bit about the San Francisco response in summary. In terms of clinical disease, we know that after exposure, people incubate for about 7 days, up to about 2 weeks in some individuals. And the top 5 symptoms that people have with clinical disease, which have flu-like symptoms in about 80% at the beginning, are fatigue, fever, lymph node swelling or lymphadenopathy, muscle aches or myalgia, and sore throat. The lymph node swelling or lymphadenopathy is pretty unique to monkeypox or mpox compared to COVID. So that's kind of often a distinguishing factor, but almost everybody gets a rash at some point. In this particular outbreak, it's starting in the genital area, and the movement of the rash is really what's characteristic. So it can move from the genital area, maybe in a place you don't even see, to the face, mouth, arms, palms, and soles. And interestingly, in this particular outbreak, maybe about 10 to 20% of people are hospitalized. At UCSF, we've had 4 so far, usually with intractable pain or super infection, like from staph or something like that. And in fact, that's how people around the world usually die. It's not from crazy mpox, viremia, or virus in the bloodstream. It's really from super infection, almost like a burn patient, because your skin is so involved that you have lower defenses from the outside world. Another interesting clinical pearl from this outbreak, as people may know, is that about 25 to 30% or so of people have another sexually transmitted infection. And it's really important, first of all, not to be dissuaded by the fact that you've gotten syphilis, because you can have both or another sexually transmitted infection. And it also speaks to the shared highway or the pathway in which the virus may travel. In terms of diagnostic tests, the main test is a PCR test, just like in COVID, and we can get CT values or quantitative amount indication of viral load from this PCR test. So it's kind of interesting when people have been looking at viral load now in studies and the way in which we get back the PCR test. We have limitations of the testing. We have limitations in diagnostics because it can look like a pimple or an ingrown hair or herpes in the beginning. We have problems in diagnostics because right now it's only CLIA approved for the skin, but you can swab anything. I mean, it's a PCR test. So if you have disease only in your mouth and you're swabbing your skin until there's no tomorrow, you're not going to be positive. In fact, one of my first patient at UCSF was false negative. He had like classic Mpox all over, responded really well to treatment, but because the person didn't swab his skin appropriately, because he had a lot of disease elsewhere, and we're limited by what the official diagnostic test is. Whereas, of course, if you have disease in your rectal area, but or emerging disease in your skin, you're not going to find that test positive at that point. The CDC does have a serology test. So in that first patient that I had, I sent it off for IgM and IgG. And of course, the IgM was positive, IgG was negative based on his timing. So we were vindicated in that way. In terms of treatment, we do have antiviral drug available called tecovirimat, or Tpox. It has 2 X's, which is kind of an interesting name. And it works on the envelope of the virus. So Mpox is a DNA virus, so it's more stable than RNA virus, which is SARS-CoV-2. And it has this nice little envelope. And when you disrupt the envelope with the tecovirimat, the virus can't spread from cell to cell. And that's how it works. Some people are worried about a low barrier for resistance, but so far so good. It's FDA approved for smallpox as of 2018, based on animal studies, because there aren't a lot of people with smallpox, so it couldn't really be studied or approved based on the basis of human studies. But we are able to use tecovirimat based on an emergency access IND from the CDC, which is another cause of inequity because many centers can't have the machinery or the willpower to put everything in place. The biggest limitation is, of course, time. It takes about an hour to do informed consent. If you're Spanish speaking, there is a Spanish version, but there are many barriers and probably leading to some of the inequities that we're seeing or disparities. The second time sinks are, of course, in the follow-up visits because it's still considered an investigational drug. And I would say, like, wearing a clinician hat, the drug works like gangbusters. Wearing a scientific hat, there are no clinical trials. There's no randomized control trial. So I don't have a control group, but I would say that, it's very well tolerated. People complain less about Tpox than ibuprofen or Tylenol, mainly because people are probably so motivated to take it. And right now we're treating the sickest of the sick. So it's kind of like in the early days of COVID, where we're treating the people who are coming in with more severe late disease, either near the eyes because it can cause blindness, the mouth because you can't eat or drink, the rectal area or the urethra, or if you're immunocompromised, underage or pregnant person. But really, as an antiviral, it's probably best you're treating it when people have early disease like Paxlovid for COVID. So in the UK and other places now, they're studying that earlier phase. So the same group who showed that steroids worked in COVID have just unveiled a 500-person study to look at mild or moderate disease and whether or not tecovirimat can reduce that length. We have 2 million courses in the national stockpile. So we're not like limited by that number yet, but we do have limitations in who can give it. And that's really leading to a lot of inequities. Although one would say that from a scientific perspective, we don't really have evidence that it works except in animal studies and just from anecdotes or case series. At UCSF, we've treated about 35 patients so far. There are other sites in the city that are treating it. Are able to treat include City Clinics, Zuckerberg San Francisco General Hospital, and the Kaiser system for severe disease. In terms of vaccine, I think, we've heard a lot about it, but we're really just scratching the surface of the demand in San Francisco. But I am worried that, with 10-minute wait lines at the general a week ago, that, again, to Dr. Cody's point, if you have a random clinic and nobody knows when it's going to happen, and it's kind of like French laundry tickets, nobody can really take time off work to rush out and go and find it, or take a whole day off, like I know some people did, to chase clinic from the general to Steamworks back to somewhere else and communicate by their mobile phones. So it is probably leading to an inequity in who's getting the vaccine, probably against people who are essential workers and people of color. We are not obligated to report who's getting the vaccine. So again, when that comes out, I'm sure we will see some of that happening. And the fact that the wait line is getting shorter, even though we're just at the tip of the morning of demand, really is concerning as well. We're really thinking that we need 70,000 doses in San Francisco, conservatively 35,000, and we're not even close to that yet. So that's basically some of the comments. In terms of response of San Francisco, I think they've been really trying to coordinate. The people who are treating get together occasionally, even in the hospital system, to talk to the DPH. We try to standardize who we're treating, how we're treating, and what criterion we're using. I think we've diversified from just city sites to include partnerships with UCSF, for example, to give vaccines. So UCSF, we've given 1,100 doses, ordered 1,500 this week, and had 7 clinic days already. But the bulk is given at Zuckerberg San Francisco General Hospital. I think, like Dr. Cody said, there are lots of challenges in equity, both in terms of who's getting tested. Like, to get asked for Monkeypox test, you have to say essentially, I've had multiple sex partners. I'm open with my sexuality, and that may be limiting in who's going to get even a PCR. Inequities in treatment, and then in vaccines, communication, and contact tracing. So thanks a lot for your attention.
Thank you so much, Peter. I know that you have a lot to share, and hopefully we'll have a few minutes at the end for some additional questions. But I want to move on to Michelle Berry. Michelle?
Thank you. Can I have my slides, please? I'm going to talk to you a little bit about the history of monkeypox and some of the work that Stanford is doing with wastewater surveillance. May I have the next slide, please? So just as far as the history of it goes, as Dr. Rutherford said, it's an orthopox virus, but interestingly enough, the name is a misnomer, as it was mentioned, and actually multiple species can actually have monkeypox or MPX. Basically, you can see it in cows, horses, camels, and a variety of rodent species. The original reservoir is really unknown, but it is probably a rodent. It was discovered, though, in monkeys in 1958 in Denmark in a laboratory, but the first human case wasn't seen until 1970 in the DRC. Next slide, please. Now, what's kind of interesting is that past outbreaks are a little bit different than 2022 outbreak. The cases were limited, and I'm going to show you a timeline. In 2022, as Dr. Rutherford nicely demonstrated, it's in multiple countries. The transmission in Africa was primarily zoonotic. There was contact with rodents or other animals, whereas in 2022, it's person-to-person contact. But that's also, we can talk about this a little bit later as to whether it's on fomites, and on surfaces, and how long it lives on surfaces. The presentation in the past is skin, and in 2022, skin, genitals, and rectum, as Dr. Chin-Hung mentioned. There is a way, one of the ways that in Africa people were dying is really with encephalitis, where the virus disseminates to the brain. The mortality in clade 1, which is the Congo Basin or DRC, is about 10%, whereas you saw that it's a handful of people that have died in clade 2B, which is what we're undergoing right now. And in West Africa with clade 2, it was 1% mortality. So there is a real difference between these strains. May I have the next slide? And I wanted to show some interesting pictures of monkeypox versus smallpox. And as you can see, it's really hard to distinguish it. And when the first cases of monkeypox occurred in Wisconsin, and I'll tell you a little bit about that outbreak, there was great fear that that was smallpox. And as Dr. Chin Hung mentioned, one of the distinguishing features from lymphadenopathy, one of the distinguished features is big lymph nodes, or what we call lymphadenopathy. And it's interesting, there's a question whether there's cross protection from older past smallpox vaccines. As you may know, one of the vaccines that we're giving now, not really the primary vaccine, is the smallpox vaccine. May I have the next slide? And so here's a timeline of monkeypox to what's happening now. In 1958, we talked about how it was identified. I want you to look at the upper slide where it's blue, where, we did a wonderful thing with smallpox. It was the first virus that was really eradicated. And you can see in 72, we stopped vaccinations, and all of a sudden monkeypox starts to circulate in the DRC way more. When we eradicate smallpox officially in 79, the WHO got very nervous that monkeypox would actually take over the niche of smallpox. And so they enhanced surveillance. But so the question is, was it that enhanced surveillance? But there was no doubt that as smallpox immunity waned, the number of cases really escalated in Africa, but nowhere to the amount. It was circulating in about 11 countries and nowhere to the amount that we're seeing now. There was a spillover from prairie dogs, pet prairie dogs, that were sent. They were housed with a sick Gambian rodent, a pouched rat, who I have no idea why people have Gambian pouched rats as pets, but they do. And this sick, there was transmission to a prairie dog, and there were actually 72 cases, mostly in children. And there was some family clustering in that. And in 2017, as Dr. Rutherford mentioned, there was a change in the epidemiology. And actually, there was a very nice Nigerian paper which showed that all of a sudden it was being what, now I have to say, I think this is sexually transmitted. We find monkeypox, and again, as Dr. Cody mentioned, we don't know enough, but we find the actual virus in semen, and it's clearly being transmitted with sexual activities. So this is what the Nigerian epidemic was identified as. And now you know that we have this huge outbreak. May I have the next slide? And we can have an argument about that later. But as far as Sarah Anderson asked me to talk a little bit about what Stanford's doing with wastewater surveillance. And it's really, these are Ali Boehm's slides, and she is the queen of wastewater. May I have the next slide, please? And just to let you know, wastewater is a community composite biologic sample. It really, we shed, and this is not, wastewater is not just feces. When you take a shower, your skin sloughs and goes down the drain, and that goes into wastewater. So that you're actually seeing feces, urine, we see sputum sometimes, all of which appears in wastewater. And it really is, it gives you the ability to evaluate community health with much less bias if people are stigmatized and don't go in for individual testing or case identification. As Dr. Chin Hung said, it may be difficult where you don't see an obvious rash. And it promotes health equity by inclusion of underserved groups. Next slide, please. So what Ali has done is started SCAN, which is Sewer Coronavirus Alert Network, where they do daily sampling with quick turnaround. They started in mid-November 2020, and what they've seen, now they have about 8 to 12 plants. They range from a plant in Stanford of 10,000 to larger areas such as San Jose, 1.5 million that they're sampling, and Sacramento. And when they sample, they actually do 10 replicates of each sample. They look for SARS-CoV-2, both the variant, not only Delta, Omicron, but also the variants. They look for respiratory viruses, and I'll say a few words about that. And they look for emerging viruses such as monkeypox or MPXV, which is what California is now calling the virus to diminish stigma. Dr. Bohm is trying to expand this to 300 plants nationally. So far, she's had philanthropic support. It would be lovely if there were CDC support or more philanthropic, because this really is a great way to actually surveil what's happening. May I have the next slide, please? So there is, and the reason why it is that there's a strong association between wastewater measurements and case reporting. The red line here shows you the case reporting, and also the blue line is the wastewater. And as you can see, very, very good correlation until about July or so of this year, when all of a sudden self-testing became really available. Actually, it started before July. And so people were not, they were not being reported. And you saw a real drop in cases, but yet look at wastewater. It's still circulating. So we're still in the midst of a COVID epidemic. May I have the next slide, please? And I think it's really good to actually be able to see that pattern in wastewater. She also looked at influenza. This just shows you how you can actually show, potentially predict an epidemic. And this is an epidemic that happened of RSV, respiratory syncytial virus, which is a virus that's quite dangerous to children with asthma and also elderly. And what you can see that they can predict via wastewater. And this was a passive influenza, because all of our athletes were being monitored with looking for influenza, and they predicted an influenza outbreak. So wastewater can be used for prediction. May I have the last slide, I think? Oh, next to last slide, which this is the slide about monkeypox, which can show you that they've been doing their surveillance, and she's very nicely shown that in Southeast San Francisco, San Jose, Sacramento, Oceanside, you can see all of the red ones are positives. And what she's also been able to show, which is not in this slide because it's embargoed and it's about to be printed, is that MPX, you can see that as it goes up, there's been a correlation, or very promising correlation, showing cases. Now, as you heard, this is not up to date. And as you heard, that there has been a drop, and there's been a drop in wastewater as well, as Dr. Cody reported. I have the last slide. So the last slide is really visionary about what wastewater can actually do. And really, if you sample and find the organisms, you can think about tweaking your vaccine quickly, as mRNA vaccines are able to be designed quickly. You can think about whether you can find out whether there's resistance with therapeutics. You certainly can think about hospital resourcing, how many people you're going to need in the hospital if you're predicting a large epidemic. And you can tell the disease epidemiology and what we need to do for pandemic response. Thank you very much.
Thank you so much for giving both the history and the wastewater surveillance. Very, very interesting. I want to now turn to Brett Andrews.
Hi, Mary. Thank you, everyone. Good to see you. Good to see everyone. I'm going to hopefully try to give you a couple minutes back. So we're going to move pretty quickly through this. Mary, in your opening remarks, you were talking about the many ways in which we've all, for many of us, been through HIV, COVID, and now monkeypox, and then the connective tissue and through line that is there, specifically sort of the psychological challenges that come with that. Real quickly, I just want to give Dr. Chin Hom a nod for getting a French Laundry reference in his presentation. Who doesn't love that? So good to see you, Peter. I haven't seen you in years. You look good. PRC is a direct service provider. We started in 1987 as an HIV organization, providing legal advocacy and workforce development in the community. We were born out of the crisis, like many nonprofits in San Francisco and across the United States. Most recently, over the last 5 years, we've gotten into behavioral health work through a series of mergers. We provide residential treatment care, across 9 licensed sites through San Francisco. Why monkeypox is so incredibly important for us is we provide congregate care. So in these sites, we are obviously trying to keep people safe from COVID, and now we have to add added protocols in monkeypox as well. So next slide. What we're experiencing here at PRC, thank you, is not only at the community level with our clients, but with many of our staff, is just this heightened trauma and PTSD that many of them are experiencing. There is heightened suspicion among and throughout the community, great amounts of fear, often that is because of the lack of knowledge and understanding. So we have done extraordinary work in meeting with our staff to help them through the process of sort of emotionally metabolizing what monkeypox is, what it means, what's its interplay between COVID and HIV, and really playing from a strength-based approach, which is we have gotten through this, we have been through this before, and we will get through monkeypox again. Next slide, please. So in our response, we continue to meet with our clients and with our staff we are promoting heavily education, linkage, and referral. I do see Clarissa, who is on here, who is the San Francisco Community Health Center. We have great partnerships with our sister organizations in the San Francisco AIDS Foundation. And so we have developed our internal policies that we have just rolled out a few days ago. We have strengthened partnerships across the community, and we're going to talk a little bit more in the next couple slides around the advocacy that we are doing. Next slide, please. So in terms of our internal policy, we are addressing issues of transmission and then the clinical presentations, many of them that were referenced here. What does it mean and what should you be looking for and paying attention to in terms of the incubation period, internal procedures within our congregate settings, environmental and equipment cleaning, occupational exposure, to make sure that folks are very clear, given that they are meeting one-on-one with many of our clients and are spending extended periods of time in our residential treatment programs. Reporting requirements both within the organization and to the Department of Public Health, and then educational materials that we have posted throughout all of our facilities to make sure that everyone is aware and language appropriate as well, in Mandarin, Cantonese, and in Spanish. Next slide, please. We always seem to get to that place. A little bit more about the advocacy that we are doing. We are in partnership with other organizations, really working hard to push for a $38.5 million investment to support monkeypox in response to the activities. And that is a state ask that we have out so that it can move through and fund our local jurisdictions. I believe Dr. Cody mentioned the underfunding that is there, and frankly, the siloed and restricted funding that we really can't use, and has made it incredibly difficult in creating barriers for really getting the appropriate PPE and necessary education and services to this emerging crisis that we have. We've also worked really hard on the reimbursement for many of the nonprofits who have had to spend a lot of their funds directing from the current services that they're providing, that then led to funding that we were using for COVID and now we're using for monkeypox. So we're working with the mayor's office and with the Board of Supervisors to identify resources there. We've worked hard to increase paid leave and financial support for those who are testing and needing treatment and vaccine and the overall period of recovery. I don't know if anyone is able to click back on the last slide and then move forward to see if it could move forward. We've worked hard to make publicly available demographic data to both our clients and our staff on the vaccine administration and treatment access. And we are prioritizing, of course, BIPOC, gay, bisexual men who have sex with men, transgender individuals, and other vulnerable populations. And then, of course, we're continuing with our pedal to the metal of pressuring the federal government to identify resources for California so that we have the adequate amount of vaccines and the guarantee of access to treatment and to services. I just wanted to say a note around Dr. Cody. Our staff are bone tired. They are incredibly tired. And we have already had a workforce shortage, certainly in the nonprofit sector. I know that it is being felt across the counties as well. And so we're doing all that we can to provide as much in terms of support, social, psychosocial, and other types of support, just to keep our clients safe and to keep our staff in the job and wanting to do the work that they do on a daily basis. Next slide, please. That was my last. I just want to say, if you want to visit and find out a little bit more about the behavioral health and HIV work that PRC does, please visit www.prcsf.org. And I just want to thank everybody for their time. I've learned so much in this short amount of time. I just want to thank everybody for the respective roles they play in helping to address this crisis.
Thank you so much, Brett. And now I'm going to ask Clarissa, if you could give us a little more detail on what's going on at the San Francisco Community Health Center.
Great, thank you so much for inviting me. San Francisco Community Health Center is an LGBTQ BIPOC organization that provides medical and social services to those living in the Tenderloin district of San Francisco. We started out as an HIV service provider to the Asian Pacific Islander community. About 35% of the population that we serve in our agency is homeless, and there is a large percentage of people who are unstably housed in single room occupancy hotels as well. Next slide, please. The Tenderloin is an example of the dichotomy of resources existing in San Francisco. We've had a lot of gentrification over the last few years with the influx of the tech industry and large buildings such as this, and in their shadow you can see people living, if they're fortunate enough to have a tent, or in makeshift shelters. A count of the homeless done earlier this year in February documented that there were approximately 3,900 people who were homeless, designated as homeless, living in the Tenderloin area. Next slide, please. And this is just to demonstrate that more than 50% of the clients that we serve are people of color. Next slide. 2 years ago, we were challenged as a community to address COVID and how it affected our community and how to respond. And during that time, the Tenderloin had some of the highest rates of COVID infection and some of the lowest rates of vaccination. We were able to partner with several community members to provide a low barrier, easy access COVID vaccination efforts. And we learned a lot by trying to address the COVID pandemic here in San Francisco. So what we did learn is that even providing low barrier access for our community isn't enough, that there are some people who are just unable or not to come even to an outdoor vaccination site, even 1 block away. So you can imagine, if we have these mass vaccination sites, as previously mentioned in San Francisco, miles away from where you're housed or not housed or staying, they're just not going to make it. So we have people that we knew were not going to make it to any of these vaccination efforts. So we were able to mobilize. We actually put together, through the efforts of our street team, a mobile COVID vaccination team with vaccine, and we would actually go block to block by foot, offering vaccination to the community. And In doing this, we were able to increase the vaccination rates in a originally very low vaccination rate community to some of the highest rates of vaccination in San Francisco. And through COVID, we learned that education was needed through peers. And so a peer ambassador, community ambassador program was initiated, and we still have those community ambassadors to this day, who are people of the community who go out and educate the community about COVID. Some of the challenges that we're seeing with monkeypox or MPX is quite different. Our street medicine team has been going out, and what they're finding is there is a great void of knowledge of this virus. Some people have never heard of it, and I've actually seen and diagnosed patients in clinic who didn't even know what I was talking about. So there is a real gap in information to the community that we serve. There have been some people who have even gone as far to say this may be a fictitious disease, that this doesn't really exist. And combined, that this means that there's a lot of people potentially who are unstably housed or living on the streets who don't know their risk factors, don't know how it's transmitted, and they're not likely to seek care. So they're not going to be the people who are going to come into a brick and mortar building inquiring about a rash or coming in and asking for a vaccine. The other issue is that, we tell people to isolate for 14 days. Well, that's almost impossible when you're living in a tent or on the street, or you have nowhere to go. And at this point in time, there's no SIP housing or in shelter-in-place housing as we had for COVID. I know the Department of Public Health is trying to work on some solutions for this, but I think we don't really know what's going on in our community in regards to monkeypox. And I think potentially this could be a problematic outbreak. We know that we do have to provide low barrier access to these vaccines. The Department of Public Health has been helpful in providing us with vaccines and supporting our efforts, and also providing us with Credo cubes that allow us to transport these vaccines and keep them temperature controlled. But this is a laborious effort. When you can imagine a team goes out, it's a multidisciplinary team, goes out and confronts people or meets with people on the street, there's a lot of education and a time taken to educate regarding the disease and regarding vaccination and why one would be vaccinated. To date, the uptake for monkeypox vaccination has been very low, which is really concerning. We also have, in response to trying to make low barrier access to our community, we have drop-in programs here at our agency for people who need services, who might have HIV or our transgender population. And as part of their drop-in services, we have been able to offer the vaccination. We are utilizing our peer ambassadors to help educate the community, and we are now collaborating with other service providers in our immediate community in the Tenderloin to bring the vaccines to them, such as the Tenderloin Housing Clinic, who has about 23 buildings in our community that houses hundreds of people in these SROs. And this afternoon, we will be going to Larkin Street Youth Services to hopefully provide vaccination to 60 at-risk young people who are not likely to seek vaccination by going to some of the other sites in the community. And as Brett said, there's strength in partnerships. So we're always looking to partner with those in our community so that we can get people educated, vaccinated, and protected. Thank you.
Thank you so much, Clarissa. That's really amazing work that you're doing in a very high need community. For those of you who are on this webinar. We are going to go a couple of minutes longer than 10 o'clock. We have a really great presentation now from Dr. Huma Abbasi, who is Chevron's Chief Medical Officer, and she's also one of our Bay Area Global Health Alliance board members. And that'll be followed by Mike Stein, her colleague. If we could put the video on, please.
It's great to be participating today virtually with esteemed colleagues from such a diverse group of institutions. And thanks to the Bay Area Global Health Alliance and UCSF for hosting this session. Hello, I'm Huma Abbasi, General Manager, Health and Medical at Chevron. While I would prefer to be live, I appreciate being able to share some of our Chevron experiences and learnings as we move forward with addressing monkeypox. As a private sector global organization, having managed to manage infectious disease outbreaks is nothing new for us. In fact, we've had protocols and processes established from past responses like Ebola, Zika, HIV, and then very recently with COVID-19. Like many, our response and business continuity plan were reviewed and updated throughout the COVID-19 pandemic, which has certainly led to some improved efficiencies and cross-functional and sectoral collaborations. Our monitoring and surveillance has been very similar, like we had in the beginning of COVID-19, where we brought together the internal teams, whether it was regional medical teams or local medical directors and medical teams from where the outbreak was very current and increased. And we wanted to make sure that we inform our employees and have them stay informed with some very trusted resources. Also, some of our public health team was activated, and we wanted to make sure that there's continual research and monitoring and surveillance established. All of which has enabled us to provide current updates with our global health and medical teams, and with our internal teams like emergency response, HR, and some of the senior leaders who were involved previously in the pandemic response as well. One of the critical piece that I want to share has always been communication. We certainly saw some very good examples of communication and some not so good, but it has been a learning experience for us during the pandemic. And now we are very, very mindful of when to engage each audience, our target audience, what we need to engage them with, and what platforms work the best and how to use them. There is a balance of what we need to communicate to the leaders, to employees within the health professionals, employee resource groups, and partners. So for instance, as an example, we initially set up a subtle message and link to general education resources on our internal company website. We really wanted to make sure that we provide the trusted resources for our workforce and reduce the misinformation that even started with, unfortunately, with monkeypox as well. And we wanted to make sure that that internal landing page and that link is quickly established. We also developed a presentation on stigma with monkeypox, in part due to what we began to see happening through the media and in discussions with some of our employee diversity groups. And I think that has been very, very important in the past responses as well as with monkeypox. All of these activities and actions have grown out of our continual improvement processes that we have established within our health and medical and public health teams. Some other key takeaways that we have been working on proactively are: one, is getting ahead of and addressing misinformation, which I already mentioned, very, very important, and key communication strategy. The other one is making sure we address stigma thoughtfully and in a timely manner, making sure that there may be some groups who are quite sensitive to the information that's sent out. Being mindful of the timing in our communication and very clear on the intent and action. For example, an initial communication may be around on how you monitor the situation with key evidence-based facts. But be cautious of sharing too much and that the information can become outdated within hours. Repurpose materials for efficiency. Sadly, we see some of the same themes that we saw in the earlier pandemics, even in the later infectious disease outbreaks. Be proactive in engaging with the key stakeholders and the business partners. And we know that we have relied previously in the past, especially through our journey in HIV and COVID-19, we saw that partnerships were important and they have always been important. And we wanted to make sure that we understand our partners' needs and participate in activities and help out with their key needs and concerns. So these are some of the things that I wanted to share here. I wanted to thank you for the opportunity here to help me share some of these messages virtually. And one of my global team members, Mike Steinberg, is in attendance today and will be happy to take some of the questions and comments that come into with the session today. Thank you.
I'll just add a couple of other takeaways about, we do take, and we've always taken a risk and a magnitude of threat-based approach when, in protecting the health of and safety of our workforce is primary, of course. We also approach all of this with our partners in leveraging our networks and our partners in our science. Many of the people on this call today, we've certainly leveraged or connected with to make sure that we're getting, current information, the right information, different perspectives of information. And we use that as part of our surveillance and monitoring as well. We do a lot of SME outreach and benchmarking. So we know what peer companies are doing cross-functionally, cross-sectoral companies and organizations are doing. So I won't say too much more. I know we're a little short on time, but I'll send it back to you, Mary.
Thanks so much, Mike. And I know we had a lot to share on today's call. And as both Mike and Clarissa pointed out in their comments, it is really important that we have partnerships when we're dealing with issues like this. They're key. It's what the Bay Area Global Health Alliance was formed to be able to facilitate. And we're glad that we've heard about several of these partnerships at the clinical level, the research level, and also in the broader awareness setting. So we're pleased that George and colleagues at UCSF partnered with the Bay Area Global Health Alliance to bring this webinar to you, and we hope to be able to have a follow-up to this in the near future. And thanks to all of you who joined us today, and we look forward to seeing you on the next one. Take care.